and our guest lecturer from the Carolinas Medical Center, Dr. Mike Bosse. So I'll introduce Dr. Chris Haydel, our moderator for the next session on femoral neck fractures.
Thank you, sir. Thank you. Okay, all right. All right. So we're going to go through some contemporary management strategies for some pretty difficult fractures, and I think we have some great panelists here that we're going to have help us out with these cases. So we have William G. DeLong, MD, from St. Luke's University Health Network, Michael Bosse from Carolinas Medical Center, and Marcus Sciadini from University of Maryland at Shock Trauma. So these are the objectives for the session. So we're going to talk about decision-making when looking at these fractures, whether we're going to use cannulated screws, sliding hip screws, or maybe some other things. Understand the use of Calcar anti-glide plates, and understand how to manage complications. All right, so we're going to jump in. Case one. So we have a 38-year-old female triathlete having some hip pain for a while, training for a Chicago Marathon. And I think, Dr. DeLong, you sent me this case. She had pain running the marathon or just?
She had pain. This is a woman from my tri club. She had pain while she was training for the marathon, and she ignored it.
Okay.
And what I'll preface this with, she had a stress fracture in the subtroch region of her left femur a year before, had to shut her down for 6 weeks, put her on crutches. That didn't break through, but it resolved with conservative treatment.
Okay. All right. So she's training, got some pain around mile 18, stopped running, went to her hotel, picked up some crutches, took a flight back to Philadelphia, and then 2 days later decided to come see Dr. DeLong. So we see this fracture here. First of all, I guess we'll just start with how do we classify this? So is this subcapital, transcervical, basicervical, or intertrochanteric? And this is for audience jump in. We want to get you involved. What do you guys think? There's only 9 seconds left. Got a lot of outliers. Okay. So most people thought it was basicervical. We have a couple subcapital, transcervical, and intertrochanteric. So, Dr. DeLong, what do you think as far as fracture type goes?
This appears to me to be a basicervical fracture, and this is a healthy athletic person.
Any differing opinions from the other panelists?
I mean, I think it's it started by history as a stress fracture, which became displaced. And so I don't know if those follow the same rules, right, as a regular traumatic femoral neck fracture. So to me, it's kind of a transitional fracture between a basicervical and a transcervical. It doesn't look like a typical basicervical neck, which you would expect to behave more or less like an intertroch. So, I'm more worried about it behaving more like a transcervical neck from a fixation standpoint.
Dr. Bosse?
Yeah, I think it's a basicervical fracture. The fixation is, I'm going to reserve things until I get the patient in the OR and pull out the length and take a look at her and see where the angle of the fracture is. Because it's hard to tell in an underreduced film like this.
Okay. And I want to invite the audience members, if you guys have questions throughout the session, I want you to just throw them out there for the panelists and me. Don't be bashful. Okay, so moving on, this is the past history that Dr. DeLong revealed to us, that she's had a previous stress fracture in the past from the same activity. So we'll kind of, I guess I'll preface the next audience response question with a little bit of a question. Is there any type of workup that we need to do before we fix this thing? Are you guys worried about any metabolic disorders or anything like that? And I invite anybody to just jump in and give their opinions if these things need to be primed in some way.
I don't think there's anything that's going to tell me information preoperatively that's going to change what I do. I think postoperatively, obviously, you know, you want to look at her, if she's amenorrheic, you want to look at her bone health status to find out, you know, if she is, she shouldn't be since she's a runner, but I want to see what her bone mineral density scan is and what calcium, and vitamin D, and all those levels are. But it won't change my preoperative plan.
Okay? Anybody else defend, do
I
something
agree. I
different?
mean, I think you're going to fix her fracture, and then you're going to get her a metabolic and endocrine workup post-op, but I wouldn't delay the fracture fixation for that.
Okay. All right. And what about timing, I guess? What about timing? Dr. DeLong?
Well, there's recent data that the way we used to say the quicker you fix these, the better off they are. You want to make sure that if there's any stress on the blood supply to the femoral head, you spare it by an anatomic reduction. There's data now that says that we don't have to go crazy with this, but I'm old and I went crazy with it. So we went to the
Get in
operating
there.
room. Pardon me?
Get in there. Same day?
Got her in there, yeah.
Okay.
But
Get her
I'd
done.
argue that it's already a couple days old probably, so
Yeah.
that.
Oh, it is, it
yeah,
is.
So that
At least two.
fixing it emergently is not an issue, at least in my practice. I take the time to get it, you know, if it's 4 o'clock in the afternoon, I do her the next day.
Okay. Dr. Sciadini?
I believe any study that lets me sleep at night.
Okay. I hear you.
It's a good study, right?
That's
I
good.
approve all those, yeah.
All right, we'll move on to our next question about, I guess, fixation strategy or treatment plan. So are we going to treat this non-operatively, do an RAF with cannulated screws, RAF sliding hip screw, an IM nail, or arthroplasty? All right, so we got a little bit of a spread. We have most people picking the sliding hip screw. Next up is the cannulated screws, and then 16% said IM nail. So Dr. DeLong, what do you think? What are you going for?
Well, I went for something. Why don't we ask Dr. Bosse what he wants to
Okay,
do, and
all
Dr.
right.
Sciadini first, and then
That's true.
we'll
He
see
did
what
go
was
for
done.
something.
Yeah, so I you know, whoa. So I lost my height here, so I have no advantage anymore. I like, you know, I have both sets available in the OR. I have the, you know, I don't like the DHS in young people because it rotates, so I use the blade instead, but the DHHS. And I have the cannulated screws. And if the cannulated screws, the bone stock's great, and I get a nice reduction, and the cannulated screws give me good fixation, I'll stop there. If I'm worried about it, you know, what I do is I do a low fixed angle device, and then 2 screws above that is derotation separate screws, and then depending on the angle of the fracture, we'll try to be maybe perpendicular to those. One of the bigger questions is do you do this, do you have to open the fracture and reduce it on an open technique in a young person, or can you treat this in a typical older person fashion and not open the fracture?
Yeah, so I guess when I want to clarify something. The blade, what you're saying is a side plate with a blade like the one that you hammer, not a blade
Right,
plate.
So it
correct?
slides, yeah, so it's a sliding, it's a DHS, but it's a blade instead.
Okay,
Works somewhat better in young people.
all right. Dr. Sciadini?
Yeah, I agree with Dr. Bosse. In terms of the choice of implants, I like that DHHS because it's a trade-off, right? With a sliding hip screw and young bone, you tend to get a rotational deformity as you seat the screw, and you have to kind of dial that back and try to regain your reduction after you've malreduced it. With the blade, you get a distraction displacement, but for me, that's easier to correct by just compressing. I think the other issue here, another option I would throw out there is, until you know how mobile this is, I'm not sure you have all the potential choices. And I say that just because I've seen a similar fracture or situation where it was a much more chronic, varus displaced stress fracture that didn't move at all, and she got a intertroch osteotomy. I think if this thing doesn't move easily, I think that's a really reliable way to get this to heal without going in and taking down the non-union, putting the femoral head blood supply at greater risk.
Okay. All right. I think that's a good segue to the next question. Open or closed reduction. I think we got Dr. Bosse's answer. Would you do it open? You try closed first, see if it reduces, and then open, or?
So, I've moved actually to attempting a closed reduction on all hip fractures in young patients, be it, from high energy or low energy. And if I get the reduction in the ballpark, that I would accept it. If I was doing it open, then I don't open the hip. And if I can't get it reduced, then I open the hip.
Okay. All right. So.
But you have to ask the other guys too, because.
Yeah, no, I am. I was just waiting for the results
All
to come in from the question. So most people in the audience said that they would do it closed. So, Dr. Sciadini, what do you think?
We've been pretty, sort of old school trauma dogmatic about opening all these, but I agree, it doesn't really make a whole lot of sense to say, well, you have to open these to make sure you have an anatomic reduction. But really the only way you assess your reduction ultimately is with radiographs, right? So if you can get an anatomic radiographic reduction, maybe it's not worth the additional cost from a soft tissue standpoint, blood supply standpoint, of opening it up to look at it and confirm to your eyes that reduction you see fluoroscopically really is anatomic. So I'm sort of leaning more towards what Dr. Bosse described lately.
Okay.
Yeah, I do exactly that. I want to see a good reduction. If it doesn't look good, then I think you have to look directly at the fracture site and open it up to reduce it.
Okay. Well, this is what was done. Dr. DeLong, since this is your case, I guess.
Yeah, I mean,
Describe.
I selected to use a DHS. Once I reduce this, and I actually do this on a HANA table. We have a HANA table in our OR, and if I think that I have to do an anterior approach to open up a fracture, I like using that table because you can see more around the pelvis. There's less obstruction, and you have total control of the limb with the boot. So I did this on a HANA table. It looked quite stable. I elected to use the DHS, and then I put a derotational screw in, and it came together pretty well. I was pretty happy with it.
Dr. Bosse or Dr. Sciadini, do you guys have any different preferences as far as table goes, like how you do it? How you set the patient up? Does it depend on fracture pattern or approach?
I do these all lateral on a flat top and just use manual traction and then convert to open when necessary.
Okay.
And I do them all supine on a regular old style fracture table with a perineal post and just pull the leg out and do it in a scissored position.
Okay. And then convert to open if you
Yeah,
need
just
to.
making you prep it for a possible open procedure,
Yeah.
but you're hoping you don't have to do that.
Okay. All right. We do have some 2-year follow-up here, and it looks like the patient healed successfully with this implant. I imagine she's running still.
Yeah. She continues with her congenital indifference to pain, and yeah, she is going like crazy. I had to work very hard for the 6 weeks after this operation to keep her away from this high-level activity. It was a struggle. But yeah, this healed up well, and she's quite successful, and she's winning races and doing very well.
So in somebody like this who's a triathlete or a potential marathoner, you know, do you can caution them about taking out the plate or about stress fractures beneath the plate, or do you consider maybe a nail instead of a plate in, you know, these high-end athletes?
Well, when I did this, I explained to her that there's going to be a hardware sticking out of the lateral side of her leg, and it might become painful. And if it does, we should remove it. I told her that she was one of those people that was susceptible to stress fractures. Those that get them for some reason. I didn't mention the potential for a stress reaction to occur under the plate, because the plate is there and it might do something differently. I didn't mention that, but she knew the hardware might come out. She hasn't had 1 ounce of discomfort from anything, and I think that's just because that's her. She has no pain receptors in her brain. So, I mean, if you think of all the people you've seen in your life that you know, can't get off a stretcher, and she walks into the office, and her husband's one of the vice presidents in the administration of the hospital, and they looked at my face after I looked at that X-ray, and yeah, I said, there's no poker face there, because I couldn't believe that she walked in with a hip looking like that.
I have a couple articles pertaining to stress fractures, particularly. This is a study of 14, it's a case report of 14 patients that have stress fractures in the military. Quite common there, and AVN rates were significantly higher if OR was delayed from 2 to 6 days, and sliding hip screws were definitely favored for basicervical fractures. And we'll get into some other literature later about timing. And I think one of the bigger trials that has come out is the FAITH trial that addressed the difference, or cannulated screws versus sliding hip screws. But the average age of that patient population was 70 years old, and I found this it's basically like a preliminary trial for FAITH 2, looking at the same kind of situation in younger patients, so 18 to 60 years old, comparing the two constructs and looking at AVN malunion and non-union rates. So I guess this is what's to come, to see if we can affect things in the younger patient population. All right, just one last question pertaining to this. So for this particular fracture, how would you guys treat this? Protected weight bearing, ORAF with cannulated screws, ORAF with a sliding hip screw, or some other treatment? This is a 20-year-old active person, military. Okay, so you got 13% saying that they would do protected weight bearing, so non-operative treatment. 79% would fix this with cannulated screws, and then 8% would fix it with a sliding hip screw. So
I'd fix it with something else.
okay,
I'd put a cephalomegin and just send him back to work the next day.
okay,
And you never see him again. If you treat him protected weight bearing and he's a high-end operator in the military, he's never going to go back to work again. He's out. If you put some heavy hardware in him, he's going to have the same problem.
okay. All right. Dr. Sciadini or Dr. DeLong, thoughts on this?
I think Dr. Bosse makes a good point. My initial thought was to just throw a cannulated screw or two up there and then still let him go, full bore, since you're basically doing sort of a prophylactic fixation.
Yeah.
But, a rod is much more prophylactic fixation.
So I guess for a more active patient, or a patient that you know is going to have a lot of activity, you would actually elect to do an intramedullary nail for the patient.
I mean, if the guy's the mail clerk, probably you can do whatever you want. If he's not the mail clerk and he's out, humping up and down the mountains, think of something else.
Yeah. Dr. DeLong?
Yeah, I mean, knee-jerk reaction, I thought the same thing, cannulated screws. But Mike really brings some clarity to this in this situation. Yeah, I think his selection would be perfect for this.
Okay, all right. Just some take-home points about the case. Stress fractures most commonly occur in long-distance runners. Sliding hip screws are favorable in fractures at the base of the neck, and compressive-sided stress fracture treatment is controversial. It's probably dependent on patient factors, activity level, and fracture characteristics. All right, now that we got you warmed up, we'll move into case 2. So this is a 51-year-old female pedestrian struck, complaining of pain. Consider her a young 51, pretty active patient. So we got these films here, Dr. Sciadini.
And this is
Terrible.
you hate to see this, right? Because
Yeah.
she's young, she's active, she's got comminution. It's hard to tell without some traction views, or I'd probably get a CT scan to exactly what this is. But the comminution involving the trochanteric region certainly adds a level of difficulty to the management, I think. And you can get the sense that there's some comminution of the neck. So, you know, again, going back to the dogma, if you want to open, reduce young femoral necks to make them perfect, when they're comminuted, you don't make them perfect. All you do is have the pieces fall out on the field. So, but I do think traction views would be very helpful in terms of defining better what the pattern is and what your treatment options might be.
Okay, Dr. DeLong.
I agree. We always obtain traction views to get an idea where we are, and if they're not good enough, preoperative planning tools move on to the CAT scan, and you got to try to do the best you can for this person. You have to try to do living femoral head surgery and stay away from killing femoral head surgery.
Dr. Bosse, any
Yeah, I would, I mean, my approach to something like this is to do, and if I'm going to do a fixation surgery, consider the next operation and try not to burn a bridge for the total hip she may require sooner as opposed to later.
Okay.
Is she having any pain pre-op?
No. No pain pre-op. So we have a couple videos that will illustrate the CT scan. So some axial views, and then we'll go to the next one. And then I have a 3D reconstruction. That's just a static, kind of a static AP and lateral reconstruction. There you go. That's it. So now what? Dr. DeLong, what do you think?
Well, this greater troch is comminuted. I'm not exactly sure where this fracture goes. If it goes, into the region of the lesser, I really couldn't catch that. I want to see this on a fracture table, and that's going to help me select how I'm going to internally fix this. I have a tendency to go with the cephalomedullary nail, and that's where my tendency would be.
Okay. Dr. Sciadini?
I mean, this is really, I think, an unsolved problem for us, right? I mean, there have been attempts to solve this fracture with things like proximal femoral locking plates, which have had some major failures, and other versions that maybe less so. But I think this is just hard, right? Because you've got comminution of the troch, you've got comminution of the neck. So at best, you can almost at best you can hope for a malunion with a short femoral neck, and loss of abductor moment, and at worst, they're getting a hip in short order. So that's a long-winded answer. I think I would probably shoot for a DH or DHHS with a trochanteric side plate to try to gather in the comminuted trochanteric fragments.
Okay, Dr. Bosse?
Yeah, I'm glad I get to go last. I think that this is not going to do well with any kind of internal fixation, and that I would actually, I wouldn't rush to fix this. I'd consult with my total joint partner while we did this, and perhaps come up with a two-stage plan where I would do a minimal approach with a cephalon major nail just hanging out there and let the greater troch congeal, and then let him come back in 3 or 4 months and convert that to a total hip replacement. Because I think that, if you give her, she's going to shorten, she's going to, get a malunion of some sort and have a hip that's not optimal at that age. And if you can get her a good total hip, she'll be, pretty much normal at that age.
Okay. So we'll move into it. Treatment. Okay, got most people electing to do IM nail fixation. Next followed by some type of arthroplasty, and then ORIF with a sliding hip screw and ORIF with cannulated screws. So I guess what I would ask is maybe what would be some of the challenges if you were to do arthroplasty right away? So Dr. DeLong.
Well, she's got a lesser trochanter. At worst, you have to use you have to make up her neck position. You look at the other side and see where she is and guess if it's a standard neck or KOH. And you'll have to set lateralization either with the implant or the liner on the acetabular side. So if the lesser is on and it's sturdy, you don't have to go to a calicar replacement, which is a whole nother problem. So it's not horrible to go to a hip replacement now with all those things that you can adjust, but she's 52 years old, and that's very young for a hip replacement if you can get her biologic hip to be useful.
Okay. Dr. Sciadini, anything to add about the arthroplasty?
Yeah, I think, her lesser's in good shape, but her greater isn't. So I think if she were getting a hip, you'd be having to try to gather in her abductors with a claw or something. And, I don't know how well that works in the setting of acute comminuted fracture. I think her abductors would tend to migrate north and be a problem.
Dr. Bosse, I know you commented on maybe doing a two-step treatment plan.
Yeah, I'm not sure that I'd favor an acute arthroplasty in this one because I think you have problems with the abductors. It'd be nice if they healed back in some kind of position. I think if they're probably going to stay where they are right now unless you go operate on and move them out of the way. So.
Okay. All right. Let's talk about timing. So when do we fix this? Is it an emergency? We got to take it within 6 hours. Is this an urgency within 24 hours, or C, whenever things are ready? So we have most people wanting to take this to the OR within 24 hours, followed by whenever things are ready, probably equipment, staff, you, and then next is the emerging group within 6 hours. So what do you guys think, Dr. DeLong?
Well, fractured hip is a fractured hip. There recently was a study from McMaster University. It was a multi-center Canadian study that showed that people do much better if they're done under 6 hours rather than past 6 hours. I'm a firm believer in laying in bed and bleeding is not a good thing. I recently reviewed our past year's outcome from hip fractures, and we could see that there was a significant number of people that wound up with an acute kidney injury that we weren't aware of. And that is the risk factors for acute kidney injury obviously are having kidney disease, chronic kidney disease going in, and people with normal kidneys, hypotension was the biggest risk factor for them. And laying in bed with a fractured hip, not being able to move, and continuing to bleed in that area can lead to that. So I think you want to do them as rapidly as you can. And at 52, she's less susceptible than 72. But I still think that you want to get to a plan and do it within a reasonable amount of time. I think, within 24 hours for this 52-year-old is okay. I wouldn't do this in a nonchalant fashion.
Okay. Dr. Bosse?
Yeah, I'm going to take the stance opposite of Bill's. I'm going to say I'm not going to be nonchalant about this, but I'm not going to rush into it. This is a very hard case. I think that the only thing that bothers me is the issue about, the blood supply and is the timing concerning for that. I think if the blood supply is there, it's there. If it was not there, it happened at the time of injury, it's not going to happen by being in bed and pillow traction or whatever for the next 24 hours. I think that you really have to have, a good thought process on this one, have to talk to your colleagues and come up with a plan that's going to work for the next, 20 years for this lady. So I think that I'm not going to rush her. If she comes in on Saturday, it's probably going to get done on Monday when I have my teams there, and not done on a Sunday morning with, the guys who do GYN as my back table. Not going to work that way. So.
Gotcha. Dr. Sciadini?
I think as usual, I'm going to hedge and say somewhere between B and C. I think probably 24 hours is good. Whenever could mean, whenever, really. So,
Yeah.
But I don't know that 24 hours is critical either.
Okay. All right. So just because we presented some literature on stress fractures and timing, I found a couple articles, and I think the topic is still a little controversial. This is a recent database study that was published looking at femoral neck fractures fixed after 24 hours. So 32% of their patients went after 24 hours, and they saw that the Charlson comorbidity index equal or greater than 3 pelvic fracture, upper extremity fracture, or treatment at a level 1 trauma center were actually associated with significant higher or significant delay associated with delay to surgery, and that delayed surgery was associated with major and minor adverse outcomes.
Can I make a comment on
Yes,
these
sir.
database studies? So there's
Yes,
a
sir.
study that came out like this a few years ago on femur fractures in the United States, and looked at, over 10,000 femur fractures with the same conclusion, that those that were fixed after 24 hours had worse outcomes than those that weren't fixed within 24 hours. And it's good data. But what's the problem with the data? Well, at every trauma center right now, the T-QIP and S-QIP expectations are that femurs are fixed within 24 hours. So we always target 24 hours. Who doesn't get fixed in 24 hours? The guy who's cold, coagulopathic, and has had a bad head injury, has all those other comorbidities. So they're already self-selecting to the bad group, or you would have fixed them. So I think the same thing is with the hip fractures in this group. You want to fix the young hip fracture early, and you can't take a national database and say, if we didn't fix them within 24 hours, look what happened to them. It was going to happen to them either way because of selection bias.
Yeah. So that's one of the reasons I included this study. But there's another study where the prospective randomized trial, basically comparing closed and open reduction. And basically what they wanted to see is if maybe delay to surgery affected rates of AVN. And basically they saw that a delay of 48 hours did not affect that. These are polytropin patients that couldn't go to the OR because of other injuries, like you mentioned, but they did find that posterior comminution, poor reduction, and improper placement of screws were major factors in non-union, but not AVN. So I think I think the topic is still controversial, and we have studies that say both, but maybe taking them as soon as we can would be a safe assessment, I guess, as soon as everything's ready and in line.
I think that's always a good plan.
Yep. All right, so I didn't really mention this before because I wanted to just ask about it again, and I think some of the panelists mentioned some of the adjuncts that they may use. So would you guys use any of these things? Femoral neck calcar plate, trochanteric stabilization plate, combination of adjuncts, or nothing, just the implants that we mentioned before? Okay, so about 48% would use a troch stabilization plate, 30% using a combination of adjuncts, 9% only the calcar plate, and then 13% saying none. So you guys want to comment on maybe the use of a calcar plate? Do you think it would help in a fracture pattern like this, Dr. DeLong?
Well, when you have a reverse oblique or vertical fracture, calcar plate will provide the stability you need to get an anatomic healing. And it's certainly indicated in a situation like that. If that's not the pattern, the other devices will suffice. So when you're working against gravity, I think the stabilization plate is well worth it.
Okay. Dr. Sciadini?
I mean, it certainly makes mechanical sense. I have no experience with putting one of those calcar plates on, but, you know, this is clearly wants to be in varus, and calcar plate counteracts that.
Good. Dr. Bosse?
I use a calcar plate, you know, just to obtain or hold a reduction if I'm doing an open procedure, and then I supplement that with a major fixation. So it's you know, used if I have to use it, but if I don't need it, I don't put it in.
So in additional resistive structure, you also use it for provisional
Correct.
fixation, just to kind of hold things while you put the sliding hip screw or the
Yes.
other implant in. Okay, all right. All right, just a little bit about maybe the anatomy that's associated with putting these plates in. This is an interesting study I saw. It's a cadaveric study looking at maybe the correct placement of this calcar plate, and it's basically an anatomic study specifically looking at an inferior retinacular artery that's actually a branch of the medial femoral circumflex. And what they did was they basically made a diagram in which the proximal femur would be represented as a clock. So 12 o'clock would be the femoral head, 6 o'clock would be the direct calcar, and they found basically this inferior retinacular artery was found between the 7 and 8 o'clock position. So if you put it too posteriorly, you may impinge upon the blood supply. It's something that was recently studied. I thought it was interesting. But more so, this is a biomechanical study that kind of looked at two different constructs and the use of a femoral neck calcar plate. So they used a 2.7 millimeter calcar plate, and it increased the load to failure by 83%. So it can give you a significant amount of resistive force. And it's interesting that the cannulated screw construct resisted a higher load to failure than the sliding hip screw in this particular biomechanical study. So at least from a biomechanical standpoint, it could provide a significant amount of support for your implant, whatever you choose. All right, so this is what happened in the operating room. This patient underwent an open reduction with a Smith-Peterson approach, so direct anterior approach, and it was comminuted. It was very comminuted, but fortunately, we didn't lose a lot. We didn't lose any pieces, and surprisingly, the calcar was okay. Like, it wasn't comminuted, so you get a good read on the calcar, and decided to put in calcar plate, which held things in place. And then we used a sliding hip screw with a troch stabilization plate to kind of reconstruct the greater trochanter, and also used an anti-rotation screw. And the thought process behind this was also kind of reconstructing the greater trochanter and at least distal femoral neck, so that maybe a arthroplasty could be done, like a regular arthroplasty could be done down the line. We put the hardware in, of course, through a separate incision. All right. And this is the post-operative film. So right now she's about 3 months out, and unfortunately she missed her 3-month follow-up. It was actually this past Wednesday. So I was kind of upset because I wanted to include the films, whether it was terrible or not. But she's still floating around out there. So any comments on fixation strategy or reduction or anything? Dr. DeLong?
Looks great.
Yeah. No, I'd say,
Would you, any place to acutely bone graft when you have that much comminution? I know you didn't have it at the calcar, but dorsally you probably did.
I think I might have put cancellous cubes in the superior neck, but no autograft. No autograft. One question that I wanted to put out there, and it came up before, you guys, some of you use a different implant to avoid the rotation. So how do you stop rotation? If you're going to use a sliding hip screw, how do you stop it? Because sometimes, even if you put an anti-rotation screw in, you'll be turning the sliding hip screw, lag screw, and then you'll start seeing the two implants twisting over each other. So how do you stop that? Like, how do you...
Use the DHHS.
yeah,
That's why I don't use it.
you do that, or you can just take the guide wire from the cannulated screw, a second guide wire, and put it across the tip of the trochanter and into the head, and that'll stabilize it as well. I mean, you really when you put this, when you use a lag screw instead of the blade, you really have to tap very well, and make sure the channel's free so you don't displace the reduction you have. The extra guide wire will help provide stabilization. I think the point of using a blade is well taken, and I think that is probably the more useful device. I've gotten skilled with using the sliding hip screw because that's what I was used to using, and so that's why I do that.
Dr. Bosse? Just use a different implant.
I don't use the DH. And young people, I think if I use the DHS, it rotates, and I don't have a good way to do that, so I do what Marcus does. I use the plate.
Yeah. Okay.
The blade. So there's one other issue on
Yeah.
femoral neck fracture that's out there and always debated at every conference, is do you need to do a capsulotomy because of the intercapsular pressure if you're not doing an open procedure, so you can decompress it and prevent avascular necrosis of the femoral head because of the compression of the retinacular vessels because of this increased intercapsular pressure
Right.
that Mark Swinkowski taught us about.
Yeah, I guess from my standpoint, I don't typically or routinely do capsulotomies if I do closed reductions. Dr. DeLong?
In a highly comminuted, high-energy injury like this, I can't believe that the capsule's still intact.
Well, you've opened that up anyway, so it doesn't matter, so.
Yeah. I mean, you know where this is going anyhow. So I think about it sometimes. Sometimes I'll do it in a younger person. In the elderly, I sort of take a pass on it.
Dr. Sciadini? Nope. Okay. All right. So some take-home points from this case: reduction, most important factor in preventing non-union. The relationship between time to surgery and rate of AVN is still unclear, and calcar plates are a very useful adjunct to increase load to failure and also help with posterior neck comminution, provisional fixation. All right. Thanks, guys.